let's talk about testing for ALK. Perhaps, who do you think should be who should be tested outside of the centers that are testing for a lot? I mean, in the broad standard of care, is the set of NCCN guidelines correct, or should it be broader, or should it be narrower than that? And what should the testing be? Does it matter?
So I think you should break it down into two forms. So there's a medical argument and there's a health economic argument. The medical argument is you should test everybody who doesn't have a 0% chance of being positive. The trouble is, the health economic argument is becoming more and more predominant, particularly in some countries where you say, okay, if you're testing a population that has a 5% rate, you get more bang for your buck than if you test a population that has a 1 in 1,000 rate, because, you know, to find each positive, the cost per positive then goes up proportionally. And so many places outside the US have adopted much more of a how much will it cost to find each positive as an upfront cost before you even talk about the cost and benefit of the drug. So in the US, where that is not currently the place, my policy is you test everyone who doesn't have a 0% chance, which is essentially every non-small cell lung cancer.
I would add to that in my practice, and I know there's some controversy to this, if I see a patient with squamous lung cancer who's been a never smoker or has a truly trivial smoking history, I tend to test them as well.
Well, I think that a lot of the lung cancer specialists, experts, certainly fall somewhere in that spectrum where at least saying, I think most favor at least doing what NCCN guidelines are and not...
Do you want to explain what those are?
So, I'm sorry, the NCCN guidelines, first, it's the National Comprehensive Cancer Networks, which is a collection of experts in many different kinds of cancer, each in committees devising what they think should be the prevailing standards for management of their cancers. From initial diagnosis, what tests do you do, to treatment interventions and follow-up, long-term surveillance and people who may be cured. All of these things tend to be covered, and you can access the site. There's some patient information there too. They have, for each tumor type, a set of physician recommendations and then what patients should know. And so these are ideally evidence-based, mostly evidence-based, and so the guidelines change every 6-12 months as new information comes in, and the current recommendations for lung cancer, advanced non-small cell lung cancer, is to test for EGFR mutations and ALK rearrangements in patients with a non-squamous lung cancer. And but I would say that is certainly something we should be aspiring to, and not having patients automatically disqualified because they smoked for 20 years, if they are the right histology. And then I think we have seen a higher than expected proportion of patients with mutations or just happen to do well on some of these targeted therapies, say with EGFR, if they didn't get tested but they're a minimal smoking squame, they might respond just like someone with a mutation, enough to think that those with a squamous histology and a less significant or no smoking history are among the most compelling to test as well. Whether to test those who are smoking in your office with you and have a squamous history, squamous tumors, is a bigger question. And I think that the challenge today is that we are somewhat serving two masters, and that it's challenging to ignore the cost card these days, certainly outside of the U.S. and now increasingly in the U.S., and that's where some of the debate stems.
Well, I think there's, please.
I was going to give you guys a shout out. So, I mean, Jared's institution was one of the first to really show that this bit, whether you have adenocarcinoma or squamous, it sounds like it's an absolute, but it's a subjective determination by a human being, and, you know, deciding who to do a definitive molecular test on the basis of a subjective observational test is an issue. I don't know if you want to comment on that.
Yeah, so my colleague, Dr. Junko Grilly-Elson, basically showed that even expert thoracic pathologists are not nearly as good as we'd like them to be at distinguishing squamous from non-squamous histology. It's a really big deal in an era where not only just who to test molecularly and where you're going to find treatable molecular changes, but even basic chemotherapy, things like pemetrexed, otherwise known as Alimta, or bevacizumab, otherwise known as Avastin, where their safety and efficacy is very dependent on what type of cancer a person has.
Yeah.
I just wanted to add that I think this debate is incredibly important in the year 2014, because I think in the world, we're failing to do a lot of good because we're not testing a lot of people. And so I think a lot of the education going around, a lot of these conversations about who to test is critically important. But I'm actually rather hopeful that in 10 years, or maybe even 5, that this whole conversation is going to sort of be very yesterday. That with a declining cost of testing and a movement towards multiplex testing, meaning testing everything at once, that I think it's going to become more like breast cancer. When you're diagnosed with breast cancer, you immediately get ER, PR, and HER2, markers that help determine what kind of cancer you have and what you're going to treat. And I would put down a good amount of money if anyone wants to bet against me that certainly by 10 years that's going to be the case in lung cancer, and that we're not going to have to debate who to test.
Well, let's talk about multiplex testing, this concept of being able to send your tumor tissue for a whole array of tests at once rather than cherry pick, I want EGFR and ALK and that's it. And then if you decide you need something else, you send a separate test, more tissue. How does that stack up compared with the tests that there is a companion diagnostic, meaning there's a specific test that is paired with Xalkori from the FDA approval that says you need to be positive on this test. How relevant is the kind of testing, and is it going to be obviated? Should it be obviated by multiplex testing? Are there differences in the results you get from one platform to another? I know you're doing a lot of this, Alice.
Yeah, so I mean, currently the FDA-approved test is this FISH test that you've probably heard about. FISH is fluorescence in situ hybridization. It's a very specific assay that was developed as the companion test during the clinical trials of crizotinib. And in fact, if you look at the label of crizotinib, it says that it's indicated for patients with ALK rearrangement as determined by an FDA-approved test. It doesn't specifically say FISH, it just says an FDA-approved test. So that leaves open the possibility of other tests, and they are coming along. In fact, the next test that will probably be approved is going to be immunohistochemistry, which is a way of looking at the expression of the ALK protein. It's a different test altogether compared to FISH, and I would argue it's an easier test to do, and it'll be much more accessible, particularly in the community, than ALK-FISH testing is. And you can imagine this, we can expand the testing from FISH to immunohistochemistry and soon to next generation sequencing, which many labs and academic centers already are doing. So in fact, at our center, for example, we do a next generation sequencing assay to look for ALK rearrangement, and then we do follow that up if someone's positive by an ALK-FISH test because it's the FDA-approved test. So you can see that the testing situation is actually quite complex. It's actually evolving and quite quickly, and there will be more than one type of diagnostic to identify patients for crizotinib.
Yeah, we've actually, before you got here, there was some discussion of discordance between them, and how often do you see that? Is the FISH test very fallible?
I think the FISH test is tricky, and I'm going to also have Dr. Cammons weigh in on this, but I've certainly seen it go both ways, false positive FISH tests and false negative FISH tests. It's a tricky assay to do. It requires a pretty experienced pathology lab and pathologist who's interpreting the signals that are seen on this FISH assay. And so I've had cases that were called ALK-FISH positive, and then the patient went on to crizotinib and didn't respond, and so we repeated the ALK-FISH, or we did a secondary type of assay, and they truly were negative, and the opposite as well. So that is a little worrisome. I don't see it that commonly, though, so I don't think it's a huge issue, but I think also it will be solved in the near future because we do have all these other ALK tests coming along.